Hi, I'm Kelly Knupp. I'm one of the pediatric epileptologists at the University of Colorado and Children's Hospital, Colorado. And I'm here today to talk about how seizures need action. And I'd like to first thank the organizers of this conference. I'm glad that we're doing this year. And I think this is an incredibly important topic because it really impacts everybody in their day-to-day lives. First of all, I'd like to share my disclosures. I actually do receive research funding and funds for consulting because people apparently think I know a lot about Dravet syndrome. And today we're going to talk about, start off defining status epilepticus, and then I'm going to talk about some of the medications that we use, particularly some of our newer medications that can be used for status epilepticus in the home setting, and then talk about seizure action plans, what those look like and what should be contained in those. So let's start off with what is a seizure. The official definition of a seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. The term transient is used as demarcated in time with a clear start and finish. So basically, it's an event that has clinical presentation that has a start and a stop and is associated with changes on the EEG. That's really important because not everything we see is a seizure. So that's the first question that we have to ask, is what you're seeing actually a seizure? And we know that there are a large number of different types of seizures, and this is the classification system that we use for this. And this is important for us to know what type of seizure we're seeing and how to treat it. And it's important when we talk about status epilepticus because just like seizures, status epilepticus can look like lots of different things. Recently, we had some definitions of status epilepticus. In the past, status epilepticus was defined as a seizure greater than 30 minutes. But since Diastat's been available in the 1990s, we effectively have been treating seizures at about the 5-minute mark. And so do we call that status epilepticus or not? And what do we do when seizures are longer? And what do we call status with different types of seizures? And so this is an approach that the International League Against Epilepsy has come up with to try and help us define status epilepticus. And they really have two definitions here, which encompass those two ideas, which is what is the time period when a seizure is likely to be prolonged and we should think about intervening, and what is the time period when a seizure has been occurring for a long enough time period that we would start to expect to see some consequences, because those two things should not be the same thing. Because we should be intervening before the seizure actually has consequences. And so this really fits what we do in clinical practice, where tonic-clonic seizures, we typically intervene around 5 minutes, but we're not concerned about consequences until that seizure is lasting around 30 minutes. Focal seizures, we may give that a little bit more time, and so we may not intervene until about the 10-minute mark, and where it takes longer to see long-term consequences with those seizures. And then they also defined absence status epilepticus, which is probably similar to the non-convulsive status epilepticus that we can see in the Dravet population, although not always exactly the same, and may not be as clear-cut where that 10 to 15-minute mark is. And it's unknown long-term if we just have no data about whether we see long-term consequences. The other thing that we need to consider, which is very important for our Dravet syndrome population, are what to do with clusters of seizures, particularly if we don't see full recovery in between each event. And they did not yet have a definition for that. So that's something that will still need to be addressed by our greater epilepsy community. As everybody who is watching this, I'm sure, is well aware, we see lots of different types of seizures in children with Dravet syndrome. And so it means that we need to think about lots of different types of status epilepticus because we may not treat them all the same. So for instance, we can see children who have absence status where they have just back-to-back absence seizures or one continuous absence seizure. And that that we would expect to present very differently than somebody with generalized tonic-clonic seizure that's evolving into status. And so typically with absence status, we would see psychomotor slowing. It may actually last for a couple of hours before treatment is sought, and it may actually be a couple of hours before anybody fully recognizes that something isn't quite right. Because we just see this sort of slowing in thinking and behavior, it's not always prominent with a clear demarcated onset and offset. Unlike a generalized tonic-clonic seizure, nobody really misses that. It's clear when it starts, and it's clear that it's still ongoing. And so that's fairly straightforward to act upon as long as monitoring is happening and we're aware that somebody's having a seizure. The same for a complex partial seizure or a focal seizure. Usually this over time will evolve into a generalized tonic-clonic seizure, but for the most part, it has a very clearly demarcated onset. For simple focal seizures, these are focal seizures that do not have alteration of awareness. They are usually not life-threatening because awareness is maintained, and so we're able to breathe and maintain our saliva and protect our airway through those. And they may not be immediately recognized because oftentimes the symptoms of the seizure are much more subtle. Something that we can see fairly often in children with Dravet syndrome is myoclonic status. This may be mixed with myoclonic seizures and absence status and may actually present as something that is more commonly referred to as obtundation status within the Dravet population or non-convulsive status. Sometimes those myoclonic jerks, though, can be so strong that it actually can be confused with a generalized clonic seizure, but typically will have a little bit more preserved consciousness with just some psychomotor slowing as opposed to complete unawareness, which we would see with a generalized tonic-clonic seizure. So why are we so concerned about this? Well, first of all, I think everybody would agree, we don't like to see seizures that don't stop. It's just scary to see these. But there are some very real reasons to be concerned about status. The first is that we actually can see a mortality rate associated with this. And the short-term mortality rate is between 0 to 4% when we look through the literature. And that is with status epilepticus that's defined as greater than 30 minutes. So we know that this can evolve into something that is really life-threatening. Although rare, that's still something that is of concern. The seizure itself also can impair breathing, eating, hydration, protecting your airway, leading to other associated issues that can impact mortality rate as well. And so that's something that we need to be very concerned about, often right from the very beginning of the seizure. Also, that demand that from the seizure can increase the needs on the body, both on the muscles themselves and fatigue muscles, and actually cause some disruption to the muscle cells where we have leaking of some of the muscle enzymes. It also can increase your metabolic needs, and that can become a problem and start to create things like acidosis. Particularly for seizures that are going on for a long time, it's almost like running a marathon with your body. And those are things that we need to be concerned about. We also know that the earlier that intervention occurs, the more likely that intervention is to be effective. And so there's lots of reasons for us to be concerned about status epilepticus and make sure that we're identifying it as soon as possible. This is some, from a treatment standpoint, a way that many providers will think about status epilepticus. We think of early status epilepticus as being the first 5 to 10 minutes of the seizure. This is something that is often being treated at home with home medications, which actually are rather quite effective. But if we don't see response in that first 5 to 10 minutes, then the seizure is more likely to evolve into something called established status epilepticus. And this is when seizures are lasting up to 30 minutes. And then once we pass that 30-minute mark, we start calling it refractory status epilepticus. And then if something has gone on for 24 hours, which fortunately doesn't happen often, but we do see in rare cases, then we start to call it super refractory status epilepticus. And from a treatment standpoint, we may approach these from very different different types of medications and escalating the interventions that we're offering throughout these different stages of status epilepticus. And I actually have a treatment card here that's been developed by the Italian League Against Epilepsy and adapted, which I think is sort of a nice tool for providers to use to think about how they're going to treat with the next step. So practically speaking, for our patients with Dravet syndrome, I usually divide seizures up into two different types of seizures. So seizures that are greater than 5 minutes. We see these most often with focal seizures and other seizures that evolve into generalized tonic-clonic seizures or generalized tonic-clonic seizures from the beginning. And these are the seizures that we need to treat fairly quickly because we'll see impairment of breathing, the demand on muscles, and demand on metabolic resources, and the risks that we talked about in the prior slides. And rarely there's any confusion about treatment or identification of these types of seizures. And these are the seizures that we usually give a pretty clear seizure action plan for how to approach. And this is what we use our rescue medicines, such as rectal diazepam or intranasal midazolam for. And that's how we generally approach these. I do have the one caveat that is particularly something that we see in kids with Dravet syndrome in our younger ages, is that if these seizures are always prolonged, if every single time you see a seizure and you know it's going to last 10 to 15 minutes, we may actually consider treatment earlier from the onset of seizure rather than waiting for that 5-minute mark to think about intervening. So that's something that's really important to talk to your provider about, because again, we know that the sooner we give intervention, the sooner we're likely to see success with treatment. On the other hand, we don't want to be giving rescue medicines for seizures that are going to stop on their own after 1 minute, because then we're actually giving medication that maybe isn't needed at all and may just be causing side effects. The other thing in Dravet syndrome that we have to consider is, what do we do with clusters of seizures? And our data doesn't really tell us what to do, and the definitions that I've reviewed don't really tell us what to do in these situations. This can be seen with any type of seizure. So probably the most common situation we see this in Dravet syndrome are myoclonic seizures, which often happen in clusters or scattered throughout the day. And I think it's really important to try to determine how much are those myoclonic seizures impairing function, because the risk of the medication and the side effects of the medication may actually impact quality of life more than the actual myoclonic seizures. And that can vary from person to person, and even in a single patient may vary over time. The standard recommendation is to treat when we have recurrent seizures with no return to baseline between seizures and they've lasted greater than 30 minutes. And so that kind of gets us out of treating those myoclonic seizures. But one of the things that we see commonly in our older patients with Dravet syndrome are brief generalized tonic-clonic seizures or hemiclonic seizures in the middle of the night, that maybe only last 1 to 2 minutes per seizure, or sometimes even as short as 30 minutes per seizure, but can occur in clusters such that somebody may see 20 or 30 seizures throughout the night. And the question is, do you treat that or not? And the child's sleeping, so it's hard to know if they've returned to baseline or not between those seizures. So that definition doesn't always help us as much as we would like it to. The rule of thumb that I generally use, my clinical pearl, is to consider treatment when you've seen enough seizures that you feel certain you're going to see more. And there's some caveats to that. So when I ask this question to families, many times they'll say, some nights I just see 1 or 2, and other nights I'll see 10 or 12. And most families are usually able to identify that once we've moved on to 3 or 4 seizures, I know that I'm guaranteed to see 5 more seizures, that it's just going to be one of those bad nights. And so that would be the situation where we would think about using a treatment to intervene to try and prevent the subsequent seizures. The other things to consider, though, is, are there more side effects with the medication than the seizures would have created the next day? So if you were to continue to have those 10 seizures through the night, but the child wakes up and is functioning perfectly fine the next day, and those seizures don't seem to be intervening, and the seizures are otherwise brief and they're able to maintain oxygenation, that may be a cluster of seizures that we don't think about treating. Because if we were to give rescue medicines, we just make children sleepy the next day and they're not able to function as well. And so we potentially are causing more problems with medications than we are just having the seizures. That's really a crummy situation to be in, but I think it's something that we have to talk about realistically, because in the long run, what we really want to do is make sure that we're maximizing quality of life. And it may be that the right answer is to just continue to make adjustments to our preventative anti-seizure medications rather than trying to use a rescue medicine in this particular situations. Does the rescue medicine actually impact outcome? I have some families who tell me, I use the rescue medication and I won't see seizures for an hour and a half, and then the seizures will return and I'll see the same number of seizures through the night, regardless of whether I've used the rescue medication or not. So if the rescue medicine isn't actually impacting the outcome, that may be another situation where we hesitate on continuing to use the rescue medication. The other question to think about is, are there any other interventions that may help? I have some patients who typically have their clusters of seizures in the early morning hours, and families have found that if they simply wake their child up 30 minutes earlier on those days when they're having those clusters of seizures, that the seizures will stop. And so that maybe that there's some other interventions, such as waking a child, that can actually help with those clusters of seizures. And so I think it's really important to go through all of these things to make sure that we're recommending the right treatment and the right approach for an individual patient. And of course, always remembering that we do have our preventative anti-seizure medications, and that it may be better to make adjustments in those rather than using a rescue medication when we see these clusters of seizures. And then the last situation that we should think about is non-convulsive status. And this can be really tricky. These often involve absence and myoclonic seizures in children with Dravet syndrome, or can occur after a larger motor seizure. I think it's a little less clear what seizure type we have in that situation. This often can be difficult to recognize, and what families will often describe as a change in function with slowed responses or unexplained confusion. And it's usually something that kind of evolves slowly, so it doesn't always have a clear onset that at 12:15 today, suddenly my child was confused. It's usually school didn't think that the child was quite right, called me to pick them up, and they were slower in their responses, and I wasn't sure if they had just missed a seizure or if there was something else going on, but now it's persisted for a couple of hours. Sometimes we may actually need an EEG to try and figure out what this confusion is, particularly if we see this type of confusion after a larger motor seizure. And at times we may just decide to treat empirically and look for improvement on the EEG. Because these children are still able to protect their airway, sometimes eat and drink and respond through this, we don't necessarily intervene within 5 minutes of this, because we, first of all, didn't usually have the opportunity. And second of all, it takes us a little bit of time to figure out what the right thing to do is. But we usually do end up having to treat this with rescue medications. So let's talk about those rescue medications. What are the qualities of a rescue medication that we look for? So most importantly, it needs to be fast acting. So it needs to be quickly absorbed and act quickly. And we often use the mucous membranes to absorb that medication quickly, because it's actually faster than whenever we're absorbing something through our GI tract. And that's why we see so many rescue medicines that are given either intranasally or rectally, because we can use those mucous membranes so that we absorb the medication quickly. The medication has to work reliably. So, we want it to work every time we use it. 100% is our goal. We may not always achieve that. We also want to make sure that it's easily administered. So we want it to be something that you don't have to place an IV at home and then draw up the medication, because those may not be resources that you have at home, or skill sets that most people have at home. If we're giving it in the oral or nasal routes, it's also important for us to consider the risk of aspiration. And so we know that some of our medications can actually be aspirated and not really cause significant issues. In fact, if somebody had a breathing tube in, a medication like midazolam, we can actually squirt into the breathing tube and have it absorbed in the lungs. We know that it's safe to do that. So we always need to consider that. And one of the cautions that I think is really important for the community to know is that if it's a compound that's contained in a fat, oil, all of which are lipids, that there is risk of aspiration with that. And that aspiration risk can actually lead to something called a lipophilic pneumonia, which can be very, very difficult to treat and lead to prolonged intubation. So we need to be particularly cautious about giving medications either in the oral or nasal routes that are contained in an oil. So let's talk specifically about some of our medications. Diastat, I think, is something that everybody is familiar with, rectal diazepam. This is a benzodiazepine that we know works quickly and reliably to stop seizures. The issue with the rectal administration is it can be very difficult to administer to larger children and in public places. And so that can somewhat be challenging. And where I practice here in Colorado, our middle schools and our high schools really dread having to give diazepam because it is often in the school setting would need to be given in a public space. And they want to do everything that they can to protect the child's privacy. But it is fairly well known to schools. It's been around for a really long time. And for our small children who need rescue medicines, this is often the way that we go. So a very well-used medication. Some newer medications that have come on the market is a preparation of intranasal midazolam. In Colorado, we've actually been using intranasal midazolam for quite a while. So we have been using the IV formulation, and we use an aerosolizer so that it can be squirted in the nose. And our middle schools and our high schools here in Colorado really prefer to use intranasal midazolam. They don't have to disrobe a child. If somebody's sitting in a chair or laying on the ground, you don't have to try and move them around to get into the right location to administer a rectal medication. And so our schools have been very happy and pleased with intranasal midazolam. The Nasolam preparation comes in a nicely packaged nasal spray, so you don't have to draw up the medication as you needed to with the IV preparation that we were using before. So that is very nice, particularly in the midst of a seizure when things can feel very flustered. The other important difference is that the pH is different in the Nasolam preparation than it is in the IV preparation. And so it doesn't burn the nose as much, which definitely was an issue with the IV preparation, that it can kind of sting like pool water when it goes in the nose. And this does not have that sensation. So that's another plus for this preparation. The important thing for prescribers and families to know is that this was studied for clusters of seizures, not prolonged seizures. That doesn't mean that it can't be used for prolonged seizures, but this may have some insurance implications as they're approving this. So you may need to clarify what clusters of seizures on the prescription that you would like for it to be used. It's also only approved for children ages 6 and up. That doesn't mean that it won't work in children under the ages of 6. It just simply wasn't studied in that population. And because of the price of the medication, we're seeing that a number of insurers are refusing to cover the medication underneath the age of 6. So that's an important thing for people to be aware of. One of the differences between diazepam, which is Diastat, and midazolam, which is what's used in Nasolam, is the duration of action. So midazolam is relatively fast acting, but it also comes out of the system fairly quickly, whereas diazepam has a longer range of action. So for clusters of seizures in many patients, there may be better response to a diazepam preparation than a midazolam preparation. So that's an important thing to keep in mind as seizures change over time. We have also recently seen an intranasal diazepam. So there is intranasal preparations for both midazolam and diazepam, which we're very excited about. This, until recently, has only been available through a specialty pharmacy. I do think that there are a number of other pharmacies that are now able to access this. So that's made it a little bit more accessible to families. And this is approved for ages 12 and up. So again, we do see issues for treatment with this. In getting approval for children under the age of 12. Although interestingly, we do have dosing for younger ages that's available. I think one of the important things to talk about with families is the pricing of the rescue medications so that we can make a good choice, because we really do need to balance the cost and the benefit of these medications, particularly for some of our patients who have high deductible plans and have to reach a max before their insurance kicks in to cover medications, because there really are some significant differences here. So Diastat's been around for a long time. That's rectal diazepam, and is available for about $350 or so. There's some prices, some places where you can actually get it for even much cheaper than that. The intranasal midazolam that we use in Colorado using the aerosolizer, we can actually get for $6 plus another $10 for the atomizer, so $16. So it's pretty inexpensive. Nasalam and Valtoco have been relatively pricey, over $600. And so there are some patient assistance programs for this, but particularly for families who have large out-of-pocket deductibles, this is an important discussion to have to figure out which medication may be the right medication to use in this situation. There are a huge number of other rescue medication options that can be used, some of which can be used at home and some of which really work best in a hospital setting. So clonazepam has oral melts. Lorazepam, which is Ativan, is a liquid. The difficulty there is it does have to be refrigerated, so that can sometimes make carrying it with you very challenging, or keeping it in a location that's accessible somewhat challenging. Valproic acid or Depakote can be given IV. Also, we've used it in GI tubes and G tubes. It's just important to keep in mind that we do have to wait for that GI absorption. So it's not something that's going to work in the first 2 or 3 minutes, but for treating clusters of seizures, we may see benefit with that. Similar with levetiracetam or Keppra, we've used that through G tubes. And again, for clusters of seizures where we can wait for that GI absorption, that may be appropriate. Phenobarbital and fosphenytoin can both be used in an IM setting. Rarely do we do this, but we have had a handful of patients where this has been an effective medication for them. I'm always cautious about using phenobarbital as a rescue at home because we can see respiratory suppression. And so we always want to make sure that we have some supervision surrounding that so that we're not causing more problems than we have to begin with. Fosphenytoin, I do want to acknowledge that there are some controversies over whether it may exacerbate seizures in children with Dravet syndrome, and we don't have good data one way or the other. In my personal practice, I usually ask families if they've had any exposure to fosphenytoin, because usually one of the first 1 or 2 prolonged seizures may have been treated with fosphenytoin before anybody recognized the diagnosis of Dravet syndrome. And that may give us an idea of whether fosphenytoin works for that particular patient, because there are some patients where this has been a helpful medication. Ketamine is something that we've been seeing more often, which can be given IM, oral, or intranasal. It's not approved for this use in seizures, but something that has been used. And then we have a number of anesthetics that we'll use in the hospital setting, like pentobarbital, thiopental, propofol, in addition to using some of our benzodiazepines like midazolam in continuous infusions to help. So there are a huge number of rescue medication options available. So I think it is really important to have a seizure action plan. And I believe that every child with seizures should have a seizure action plan at school. Children spend more of their waking hours at school than they do at home. While we educate families on how to manage seizures, we want to make sure that people are educated on how to manage seizures at school as well. And I think there are a couple of key things that need to be included in the seizure action plan. First of all is how to identify seizures, particularly if they're not so straightforward. What to do if somebody has a seizure. Seizure first aid, I think, is really important. And you can see that on the seizure action plan example here that's provided by the Epilepsy Foundation. And also telling people what medication to give, when to give it, and when and who to call. And I always recommend that we err on the side of overaction. We never know who's going to be around the child in school when a seizure happens. And we want to make sure, and it may be somebody who's not familiar with your child, particularly if there's a nurse who is new to the school or is a substitute nurse. We want to make sure that we give them all the information that they need in a very concise form, so that they can review it very quickly and then act on the seizures. Some schools for complicated seizures do provide training for their staff, so that there are more people, and the people who are closest to the child will have that training, so that they know what to watch for and what to expect. And I think this is a really important thing to review with the school the weeks before school starts and in that first week that school happens. Sometimes it's important to have an emergency plan for emergency personnel as well. And for this, I often write a letter. I have a sort of standard brief letter that we write. And this is a guide that we can give to EMS or the emergency department of what steps to take if you're presenting in that situation, because it may be a little bit different than how they would typically approach a seizure. And I would also remind everybody that as a family, you are probably used to seeing more seizures than they are, particularly as your child gets older. And so in those settings, EMS and the emergency department are usually very happy to have some directions of what to do so that they have a successful outcome in managing a seizure. And so there are a couple of key things that I include in these letters. First of all, I describe the situation. So I very briefly mention that this is Dravet syndrome in case it rings any bells. Let them know that we usually see prolonged seizures and they can be worsened by temperature. And also specifically that it can be worsened by sodium channel blockers, so that they know to stay away from those medications. In here, if there are any urgent, unique issues, I will include this as well. And this is not uncommon in some of our patients. One of the biggest issues I see is that the emergency personnel are used to seeing generalized tonic-clonic seizures. And so when we see focal seizures, particularly that don't have any clonic movement with it, they often want to call that a postictal state when the family may very well recognize that it is not. And so in this example letter here, I've put the statement in that if so-and-so is presenting to the ED, her parents have already treated with rescue medicines, and that it's difficult to tell when this child's seizures have stopped. And it may be characterized by right eye deviation without any other motor symptoms. Fortunately, her mother is very reliable at identification of the seizures and will be able to guide you so that the emergency personnel knows they really should listen to mom, because we've already recognized that mom is very reliable with this. And then I try to provide as much guidance and options for treatment as possible. Colorado gets pretty rural after you get outside of some of our larger cities, such as Denver and Colorado. And so we have some local emergency rooms who may not have a lot of medication options to give IV. And so we always try to give them a couple of different options for treatment. We have also arranged for those particular EDs, if we have a child who's coming in often, to make sure they actually have the rescue medication available. So I've had some rural emergency departments where they've had Keppra or Depakote sitting there with a child's name on it so that they have access to the medication when it's time, when that child comes in. So sometimes we have to be kind of creative in those types of things. And then we provide them with reliable contact information so they know who to call and what to call for. This is all fits on one page, so it's not like they're having to read a novel. Many parents will have several copies of this letter. We try to update them annually so that if we need to make any changes, we can. And this way they have, one on their refrigerator and one that they've already dropped off to their local fire department and their local emergency department, and one that they carry with them all the time so that they can pull it out when they need it. So this can be particularly helpful to our emergency personnel. So in conclusion, I think the most important thing is to have a plan, to know what you're going to do when a seizure happens, and that can include both a seizure action plan as well as an emergency letter. Keep in mind that the needs for rescue medications may change over time as seizures change. So often in younger ages, we'll see prolonged seizures, and then as children get older, we see clusters of seizures. And so it may be that we need to think about changing our rescue medications given those different clinical scenarios. And it's really important to update these plans annually or more frequently if needs change, or if you've used your action plan and there are some things that we can do to improve that response so that we can limit the seizures. And with that, I will end here so that we can answer any questions.